I'm Harriet Vansvall, cardiologist and clinical trialist, and I'm delighted to have with me Professor Greg Stone, principal investigator of the RELIEVE-HF trial. And we are here at ACC 2024, where he is going to present his trial results at the late-breaking clinical trial session. Welcome, Greg.
Well, thank you, Harriet. It's great to be here with you.
I wonder, Greg, before we get into the meat of your trial, if you would tell us a little bit about the background on inter-atrial shunt devices and their role and their potential role in managing heart failure based on other research and trials in this space. Give us some context.
Sure, my pleasure. As you know, all heart failure, whether it's heart failure with reduced ejection fraction or heart failure with preserved ejection fraction, is characterized by increased left atrial pressure. And increased left atrial pressure transmits back to the lungs, and that causes dyspnea. And it's been shown that left atrial pressure is often substantially elevated, 24, 25 millimeters of mercury for days before it precipitates a heart failure hospitalization. And there's a lot of background data to suggest that creating a small communication between the left atrium and the right atrium to reduce the left atrial pressure might relieve dyspnea and improve the prognosis of patients with heart failure. There's a syndrome called Lutenbacher syndrome, where patients who have mitral stenosis and elevated left atrial pressure actually have a better prognosis if they have a small atrial septal defect as part of the congenital disease. We used to treat patients with acute decompensated heart failure with atrial septostomy, creating an atrial septal defect. So there's been a lot of interest in this concept, and there's about 10 different manufacturers that have developed very novel ways to either insert a shunt device that creates a very small opening between the left and the right atrium, either leaving behind a permanent device or just creating a hole with nothing left behind, to again, create a small opening that serves as an auto-regulatory mechanism. And what I mean by that is that once you've got that little hole, it's on 24/7, 365. And if the left atrial pressure is low, there's very little gradient in pressure between the left and the right atrium, so there's very little blood flow. If, on the other hand, the left atrial pressure rises, such as after exercise or eating a big bag of potato chips in a patient with heart failure, then there'll be greater blood flow decompressing the left atrium. So it overcomes some of the limitations of pharmacologic therapy, which is hard to time with those types of events.
Sure, yeah, in absence of markedly elevated pulmonary pressures, it makes sense. Tell us about this device. There's a market full of devices that have not been tested with the robustness of randomized clinical trials. Fantastic to have trials such as yours. But what about the device itself? Give us some background on it.
Right. And as you imply, there's only been one trial of any inter-atrial shunt device previously that was tested in a randomized trial. And that was in a patient population with heart failure and preserved ejection fraction who were very, very low risk. So we're testing a different device, which is manufactured by a company called V-Wave. It's investigational in the United States, but it's actually got CE mark in Europe. And it's an hourglass-shaped device, which is fully encompassed or covered by ePTFE, which makes it very non-thrombogenic. And it's implanted in the inter-atrial septum in the fossa ovalis. And it's got a 5.1 millimeter opening. It's one of the smallest openings of any of the inter-atrial shunt devices. And it allows a ratio of pulmonary blood flow to systemic blood flow of approximately 1.2 to 1. So that's basically the background of the device. And we wanted to test it in both patients with heart failure with reduced ejection fraction, as well as preserved ejection fraction, so any ejection fraction, and in a much sicker patient population where there's a much greater clinical need.
Why might an inter-atrial shunt device that's left in situ be preferable over an iatrogenic shunt without a device?
So that's a great question. First of all, it depends on how big the iatrogenic hole is. Patients with congenital atrial septal defects usually aren't markedly symptomatic and don't develop progressive symptoms unless they developed a ratio of pulmonic to systemic flow of around 1.4 or 1.5 to 1 or even greater. So the first thing is we want to create a very small communication between the left and the right atrium. And theoretically, there may not be any benefits between a permanent shunt device and just creating a small hole, except that the permanent shunt device may have a better long-term patency rate. So the particular shunt that we tested was manufactured by a company called V-Wave, and it's called the Ventura Interatrial Shunt. And it's actually got an interesting hourglass shape. It's about the size of a dime, and it's implanted in the middle of the interatrial septum in the fossa ovalis through a transcatheter procedure through a venous approach. It's a very low-risk, easy procedure for a structural interventional cardiologist. And the hourglass shape helps hold it in place because it's pinched in the center. And the shunt is fully encapsulated with EPTFE, which prevents it from developing thrombus and prevents it from narrowing over time. And the hourglass shape, it's got a very small orifice or opening in the center of it. It's 5.1 millimeters. But the hourglass shape actually entrains blood with what's called the Venturi effect. And through Venturi efficiency, it will transfer approximately 1 liter per minute of blood flow. So it acts kind of like a 6 millimeter hole, even though it's only 5.1 millimeters. And it creates a flow from left to right, or a pulmonary blood flow to systemic blood flow ratio of approximately 1.2 to 1. So much less than the types of congenital atrial septal defects that have been known to cause dyspnea on their own and then ultimately Eisenmenger syndrome. This is a very, very small communication.
Tell us about the inclusion criteria of the trial.
Okay, so we enrolled patients who had symptomatic heart failure, despite being on maximally tolerated guideline-directed medical therapy, again, with any left ventricular ejection fraction. So it could be 1%, it could be 99%. And patients had to have either heart failure hospitalization within the last year or a fairly markedly elevated BNP or NT-proBNP. And we included patients who were New York Heart Association Class II, III, or ambulatory Class IV.
And what were your key exclusion criteria?
So there were a number of exclusion criteria, such as an abnormality of the interatrial septum, if there was moderate or marked right ventricular dysfunction or pulmonary hypertension. You alluded to that in the past. Prior coronary bypass graft surgery, and life expectancy less than 1 year for non-heart failure related reasons, and a number of variety of exclusions such as that, need for chronic oral anticoagulation, etc.
I thought it was fantastic that you chose clinically relevant endpoints, certainly much more stringent than regulatory requirements for devices to get a pass. So tell us about your primary effectiveness endpoints.
Right. Well, as you mentioned, we had two primary endpoints. One was safety. And we wanted to see that we weren't going to hurt people just through the procedure. So we had a primary endpoint, which is called MACNE, or Major Adverse Cardiovascular or Neurologic Events, which is a composite of adverse events related to the device or the procedure, just in the patients who received the device within 30 days. And that was tested against an objective performance criteria that we developed with the FDA. But then the major outcome, the primary effectiveness endpoint, was a combination of 4 cardiovascular outcomes and improvement in quality of life as measured by the Kansas City Cardiomyopathy Questionnaire. And this was tested in a hierarchical format using the win ratio. So it was all-cause death, need for left ventricular assist device or heart transplant, heart failure hospitalizations, or outpatient worsening heart failure events. And that was the top 4 strata of the hierarchy, and it was followed by improvement over time in Kansas City Cardiomyopathy Questionnaire for the patients. And we followed all patients up to 2 years, and we concluded enrollment when the last patient reached 1 year follow-up.
Okay. Now, was this a placebo-controlled trial? Were patients blinded to the allocation for the primary analysis?
Yeah, that's a very important question. And we think that's very important, especially when you're using patient-reported outcomes such as the KCCQ. And yes, this was a placebo procedure-controlled trial. So of course, the physicians, the nurses, the research staff in the cath lab was unblinded. They know whether or not they put the shunt in or not. But the patient was blinded, and the patient was under deep sedation and wore mask and music playing headphones, and a script was followed so that patients who received control therapy, they had a prolonged procedure. They already had transesophageal echocardiography performed, so they were heavily sedated, and that was required to do the final qualification for the patients in the trial. And then once everyone left the cath lab, everybody beyond that point was blinded. So not only the patient and their families, but all subsequent physicians, nurses, healthcare assessors, the clinical events committee, everybody else was blinded. So the implanting physician was no longer involved.
Sure. Now, this was an international trial, how many patients did you randomize? And tell us about their baseline characteristics.
Thank you. So we randomized a total of 508 patients at a total of 94 different sites. We actually screened patients at 113 sites from 11 countries. So it was very broad, from the United States to Canada to Germany, Spain, Israel, Australia, New Zealand, other European countries. And we enrolled a total of 605 patients, and about 97 of those patients were so-called roll-in cases. They were treated with the shunt without randomization to give selected sites experience with the device. But ultimately, we then randomized 508 patients at 94 sites over approximately a 4-year period. And 250 patients were randomized to receive the shunt, and 258 patients were randomized to the placebo procedure. Now, very importantly, this was the first time that a randomized trial was performed in patients across any ejection fraction. And there was a real question whether or not the outcomes were going to be similar in patients with reduced ejection fraction and preserved ejection fraction, because the cardiac structure and function is very different in those patients. So we only had one major subgroup, and actually we stratified the randomization according to preserved or reduced ejection fraction at a left ventricular ejection fraction cutoff of 40%. And so we had basically 2 separate randomized trials. And although the trial was powered for the overall patient population, and it was hoped that those 2 patient populations or cohorts would respond similarly, we did all the same analyses in both cohorts, and that turned out to be quite important. So after the randomization, we followed the patients for, again, a minimum of 1 year and maximum of 2 years.
So interesting to note that there was a great uptake, not only of medical therapies for any given EF range, but also device therapies. I see that the uptake of ICD and CRT therapy was even better than some might see in regular clinical settings. So a point to consider when assessing the treatment effect of this intervention of yours.
Exactly, Harriet. I mean, these were patients who were also failing all those therapies. They had to be tried. If they had reduced ejection fraction, they had to be tried on all Class I guideline-directed therapies. And now there's 4 of them, of course. And they had to take them at the highest doses possible. And we had a clinical eligibility committee, including heart failure specialists, that would interview the principal investigators and understand what the symptoms were that were keeping the patients from taking higher doses or staying on all 4 drugs. So it was really very, very rigorous, similar to what we did in the COAP trial. And despite that fact, and despite the fact that approximately a quarter of the patients had received cardiac resynchronization therapy, which of course, as you know, improves symptoms and outcomes in patients with left bundle branch block, wide QRS morphology, and reduced ejection fraction. And half the patients that had implantable cardiac defibrillators. Despite all of this, they were still highly symptomatic, with approximately 95% of all the patients in the trial having NYHA Class III symptoms. They had markedly reduced KCCQ scores, markedly reduced 6-minute walk distances, and very high natriuretic peptide levels to get into the trial.
Right, and your trial population comprised older adults, sort of over the age of 72, which is quite representative of people with heart failure. What was the breakdown of EF? Were patients, I know you said you stratified randomization,
Right.
so was there an equal distribution of those with reduced and preserved ejection fraction?
Right. So approximately 40% of the patients had reduced ejection fraction. That's less than or equal to 40%. And 60% of the patients had preserved ejection fraction.
Okay, and any demographic breakdown that you'd like to tell us about?
Well, in the entire trial, approximately 62% of the patients were male, about 38% were women. In patients with preserved ejection fraction, there's a higher predominance of women, where in patients with reduced ejection fraction have a higher preponderance of men. And there were a lot of comorbidity. This was a very sick patient population because these were patients with heart failure who were not responding to medical therapies, had recent heart failure hospitalizations or very high natriuretic peptide levels. So approximately half of the patients had diabetes, 3/4 of the patients had chronic renal insufficiency. A lot of the patients, of course, had coronary artery disease, approximately 2/3 of the patients. Their ischemic cardiomyopathy was present in about half of the patients. A fair number of patients had COPD, prior stroke, hypertension, hyperlipidemia, et cetera.
Yeah, I thought it was remarkably similar to the kind of patients we see, right, in our setting with complex comorbidities. They were well treated with device therapies at baseline, which I thought was another important point, and really symptomatic across the range of severity of symptoms. So tell us about your event rates and your primary treatment effect then.
Well, thanks. And I will mention, just in concert with what you were saying, again, almost half the patients already had a defibrillator device. About a quarter of the patients had cardiac resynchronization therapy. About 95% of the patients were NYHA3. So these were very symptomatic patients, very high biomarker values, NT-proBNPs around 17 or 1800 picograms per ml. So what we found was, in terms of the primary endpoints of the trial, is that the device was extremely safe. In fact, the major adverse cardiovascular or neurologic event rate at 30 days among the 250 patients in whom the device was implanted, and by the way, it was implanted successfully in all patients, was 0%. So there were no adverse effects, which was all-cause death, stroke, systemic embolization, need for open cardiac surgery, or major endovascular surgery repair related to the device or the procedure. And FDA would have allowed an objective performance goal of 11%. So the upper bound of the 97.5% confidence limit was 1.5%. So the p-value was met with less than 0.0001. So extremely safe procedure. And that was very reassuring. But when we looked at the primary effectiveness outcome in the entire population, the primary effectiveness outcome was not met. There was no difference between the two groups. And as you remember, we had this 5-level hierarchical testing, and there was no difference in any of the levels or in the entire win ratio. The p-value for that effect was 0.20. When we broke it down into cardiovascular effects, which were like the first 4, there was no difference. And when we broke it down and looked at the KCCQ outcomes, there was of interest significant improvement in KCCQ in both groups. by approximately 10 points. So with 5 points being the minimally clinically important difference. So all the patients felt better. So a big placebo effect, even the patients who didn't get the shunt. And we had a blinding questionnaire to show that they were quite well blinded. But there was no incremental improvement in the patients who received the shunt over the background control group. Now that was in all the patients combined.
Right, and we've certainly seen this consistently. We all know about the placebo effect, but particularly in device trials, your point is important that there is definite role for a well-done placebo control group, so that particularly in trials that use health status or KCCQ, we are able to reliably test treatment effect. And so thank you for raising that point. Did you see any variation or heterogeneity in treatment effect across EF subgroups or any other subgroups?
So that's where the trial became very interesting, because if it was only a trial showing safety but lack of effectiveness, that would be one thing. But we actually saw a striking difference in outcomes in patients who had reduced and preserved ejection fraction, with a significant interaction and effect between the two. Specifically, the patients who had reduced ejection fraction had an overall 45% reduction in cardiovascular events over the 2-year follow-up, with the curves continuing to verge over time. And that p-value was less than 0.0001. In contrast, patients that had preserved ejection fraction, greater than 40%, had a 68% increase in cardiovascular events over time, p-value of 0.0001. And in the reduced ejection fraction group, there was a large reduction in heart failure hospitalizations, a borderline reduction in LVAD and heart transplant, and a trend towards a 37% reduction in mortality. In the patients with preserved ejection fraction, not only was there a doubling of heart failure hospitalizations in the patients who received the shunt, but there was actually a 3-fold increase in mortality, which was highly statistically significant. And there were significant interactions between the two groups in all of these different effects. So major differences in outcomes in cardiovascular events, according to whether the patients had a reduced EF versus a preserved EF. Now, we did have echocardiograms at both baseline and at 1 year. And the echocardiograms actually were revealing and likely explained why there were such differences. In patients with reduced ejection fraction, the heart is very compliant. The left ventricle is large, the pulmonary pressures are not so severe, and the right heart in particular was able to accommodate the increased blood flow, which is approximately 1 liter per minute of cardiac output going from left to right, such that the RV and the inferior vena cava did not increase in size. The pulmonary pressures did not increase. There was no change in overall left ventricular function to a slight improvement, and the cardiac output actually slightly increased. In contrast, in the patients with preserved ejection fraction, the ventricles were stiff, both the right and the left ventricle. And when there was more blood flow going from left to the right ventricle increased in size, the inferior vena cava increased in size, the pulmonary artery pressures increased, and the cardiac output decreased. So the right heart was unable to accommodate the increase in blood flow. And that fits along perfectly with what we saw in terms of cardiovascular events. I'll complete the picture because there was one other very important finding, and then you can ask, I'm sure, what will be lots of questions. The other major component of the primary effectiveness endpoint was the KCCQ. And very, very interestingly, in contrast to the cardiovascular events results that I just told you that went in the exact opposite direction, all patients felt they were getting better, whether they had reduced or preserved ejection fraction. every patient got better by 10 or 15 points. And it was very similar with the shunt and compared to the placebo procedure, both in the reduced ejection fraction group, even though the shunt patients had a markedly reduced incidence of heart failure hospitalizations. And it was also even more interestingly similar in the preserved ejection fraction group. All those patients felt better, even though the shunt-treated patients were having a doubling of heart failure hospitalization and a threefold increase in their mortality rate. The number needed to treat in mortality was 11 patients to cause one death over a 2-year period in the preserved ejection fraction group, which was striking to us, but the patients were feeling better, according to the KCCQ. So this raises a lot of implications about that particular measure in these types of trials.
Sure. I wanted to raise the point regarding the increased risk in the preserved ejection fraction group. I don't recall that being a finding in the reduced LAP2 trial. So you would just described really well the physiology and some of the hemodynamics that might drive it. But what are your thoughts around some of these disparate findings and important findings of your trial, particularly with regards to the subgroups?
Well, if you remember from reduced LAP2, in which they used a different shunt, it was only preserved ejection fraction. Those patients were enrolled on the basis of exercise-induced increased pulmonary capillary wedge pressure in the cardiac catheterization laboratory. And they enrolled a much lower risk patient population that had only a 1% risk of cardiovascular mortality at 1 year. I mean, for a heart failure population, almost unheard of. And they had relatively low biomarkers, relatively well-preserved, 6-minute walk distance, et cetera. And it was overall a negative trial. Well, you remember, though, they did identify some patient groups, those with an enlarged right atrium, those with latent pulmonary vascular dysfunction, and those in whom pacemakers were implanted, who either didn't benefit or perhaps were harmed. Although overall the trial was neutral, but a very low-risk patient population. We enrolled a much higher risk patient population that had about 5 times the mortality in the preserved ejection fraction group, much lower 6-minute walk distances, much higher biomarker levels at baseline. And we saw, again, perhaps because of that, significantly higher event rates, both in the control population, which were then exacerbated in the shunt group. So I think it's a little hard to compare the two trials because they really did enroll very different patient populations.
Sure. So in this well-designed trial testing the efficacy of the Ventura inter-atrial shunt, you demonstrated a neutral effect on the hierarchical composite of clinical endpoints as well as health status as measured by the KCCQ overall summary score. But interesting subgroup findings that point to a heterogeneity in treatment effect with a risk reduction in those with reduced ejection fraction. Thank you so much for spending your time with us. Congratulations on your presentation, and we wish you well for your hotline session that's coming up. Thank you, Greg Stone.
Thank you, Erin.